Good evening, everybody. Welcome to the Health and Human Services Committee meeting. It is Wednesday, August 2nd, and we are in council chambers. Tonight, we'll just have two agenda items, so it might be a quick meeting. Folks are welcome to join us in council chambers or listen remotely. However, we do not accept public comment at our committee meetings. So first, I would like to welcome our guest, John Koch from Community Medical Services, and he's going to be sharing more about an opioid treatment center that they're working on putting in here in Everett. So take it away, John.
I didn't brief you on this, but there you go.
There we go. Hello, everyone. I'm John Koch. I'm the Director of Community and Public Relations for Community Medical Services, which we are a national opioid treatment program. We currently serve about 73 cities across the United States, addressing individuals specifically with opioid use disorder. What we operate is a daily outpatient clinic. So individuals come in daily in the beginning, and then based off of just the state's regulations is the amount of times that they have to come into treatment. We are not just some pop-up company that said, hey, opioid funding's around, opioid dollars are popping up. We've been around since 1983. Our current CEO is Nick Stavros. He is the son of George Stavros, who was the founder of Community Medical Services. We take a great amount of pride in what we do. I personally am a person in long-term recovery and can say that I wouldn't work for any type of treatment program across the United States that doesn't care about the people they treat. We care so much that sometimes it's hard to do what we do because we see so much sadness working with people dealing with fentanyl and those type of drugs that can kill somebody after just one use. So take a great amount of pride in what we get to do and growing to help address the problem. A lot of what's happened in our industry and in the rehabilitation industry across the nation is companies buy other companies but don't expand organically. We take pride in expanding organically into new cities, new towns, new states, so that we can address new populations of people that weren't receiving treatment before. That being said, we provide the 3 FDA-approved medications, one of those being buprenorphine, brand name Suboxone, another one being naltrexone, brand name Vivitrol, and another one being methadone. This is the gold standard of treatment for individuals with opioid use disorder. It helps to stabilize, at least 2 of the medications help to stabilize the person's brain chemistry, specifically their mu receptors, and helps to give them a shot at not going through harsh withdrawals, but being able to go and get a job, being able to stabilize those mu receptors that have been affected from long-term opioid use disorder, and really help that person just have a fighting chance. But we also believe that medication is only one tool in the toolbox. We need to provide that person with an full circle approach. So that being said, we provide counseling, peer support. I actually was the company's first peer support specialist ever hired. It was really cool to be able to give back to other people that were going through similar situations just like I was. I once was in a clinic and had no hope, and somebody gave me some hope. And so being that person today, is a great privilege. We also provide and have started psychiatric services out of certain clinics, and it's basically just like going to your primary care doctor's office. We take great pride in the internal operations of our clinic. We've had Arizona State University come out and perform Lean Six Sigma basically training and break it down so that our average wait time as of this morning for a person that's inside of our clinics across all 73 clinics throughout the United States is 4 minutes and 43 seconds. We're very proud of that because the individuals that come into our facilities, they're just like you and I. you might be struggling at that time. And so they have kids, they have a life. You know, we open at 4:30 in the morning, not because we like to wake up at 3, but because a large portion of whom we serve is the blue-collared worker you see going in and out of your ports, in and out of your construction business every single day. That is a large population of what we treat. And so, that being said, we put a big focus on safety. So I've been with the company for 7 years. Since then, we used to hire security companies. We realized with security companies that we weren't getting what we needed from them. They weren't culturally trained to work with the population that we work with. So walking up to somebody that's maybe having the best and the worst day of their life, knowing that they're going to change, but knowing that they no longer maybe have a substance that they've used for so long to help them through situations, and having a security guard yelling at them or being upset with them because they're not moving as fast or something is not the right approach. So, and outside of that, it was just not working. We'd had several different cases of times where our patients and the community were not treated right by these security officers. So what do we do with that? We started our own internal program called a Patient Navigator Program. What this is it's individuals like myself who are out there often in long-term live recovery and can help that person, whether it's our patient or it's just somebody in the neighborhood who's struggling that you know and want to help guide us to. That navigator with a counselor, peer support could go and help that individual. The navigator gets trained in de-escalation, gets trained and helps walk people directly to their car and to the front door as if they were assisting somebody in a walker or so on, so that they know that they're safely getting to and from and not obstructing with any other businesses when we share lots with businesses. At this location, 5130 Evergreen Way, we're not sharing it with anybody. We'll have the building to ourselves. With this location, they will be gutting the inside completely, and then we will be putting in money to it. It's around 4,500 square feet, so we'll be putting in about $140,000 per 1,000 square feet. So this is about a $600,000 to $700,000 project for us as a company right now. So we are committed to Everett and making a difference here, but also being good neighbors, because nobody wants to put that type of money into a space and then in a couple years have to have somebody tell them that, hey, you need to move it, or hey, this isn't the best space, or hey, maybe there's possibility of getting you shut down or something like this. So I personally cited this space because of its access to a regular road, its parking, its availability to parking on the street, and it's in a busier section of town, so it's not going to be, having people come in and out of the clinic that drive there. It's not going to be a noticeable thing. It's just going to be like any medical doctor. So that's how we cited and got there. We use our navigators not only to work to help the patients in and out, but they're also liaisons to the community. They will be walking up and down Evergreen Way, talking to not only people that are experiencing houselessness and talking to them about giving them resources, but they'll also be talking to fellow businesses, helping to form business alliances with our manager and our regional directors that we hire and are up here, and working closely with that piece. And then, being a good community member as a company. So we, and a lot of places talk about loitering and having people loiter. We have a no loitering policy in place for our patients that is probably stronger than most city loitering policies, not because we want to make anything hard for our patients, because we realize that there is a stigma sometimes with people that are recovering from an addiction, and so We do not want to add to that, but we want to help our patients and not feeling that way either. No one feels good. I didn't feel good when people would stigmatize me walking into a place, and we don't want our patients to feel that because they're standing over by the corner. So we have like a no loitering within, a half-mile radius, and then people ask, how do we take care of that? A half mile, that's a big space. You're right. We can't be every 20 feet. We don't have enough money or enough people to do that. But what we can do is we can collaborate. And we can collaborate with your city leadership, your first responders, the local, like you said, talking to the local businesses and just being around. But with those collaborations, we do a diversion program in El Mirage, Arizona, where police, instead of having to keep taking people to the county jail that they call, at least the police call frequent flyers, we've been able to interject, and now they're able to come into our intake facility and get help that day, and then they're able to tell the police the story 6 months later. Hey, thank you. You changed my life that day. And you'll never see a bigger impact on people than when they get to do that. And same goes with fire department. We have the Maury program that's being replicated all over the United States and Milwaukee, Wisconsin, where we go out with the fire department the day after an overdose. I'm a person myself who's clinically overdosed 3 times. Each time I was handed a piece of paper and told to leave the hospital. What happened is I ended up going to get high because I was so filled with guilt and shame that I didn't know what to do. Now we have a program with fire department that we've helped develop into a program that's being replicated nationally called Maury. It's where our peer support specialist, specifically a lady named Amy, goes out with the fire department every Monday through Friday in the mornings. And if somebody overdosed the day before, she goes to their house. Fire's in the background. She goes up by herself and engages with them, gives them what's called a hope kit. It was actually on the news the other day, and helps to get them into treatment, not just with us. We don't care about if you get into it with us. We just want you into treatment that works best for you, so then they help to guide them over to that. And that's working with the different groups. That's how we stay on top of anything that's involved with loitering or those different pieces. We've worked with several different first responders to help look and see how, our clinics are affecting crime and those different things in the area. In Phoenix, Arizona, where we are most heavily populated with clinics and is the largest metropolitan area that we serve, all the areas around our clinic usually experience about a 3 to 2% decrease in crime every single year. And that's because the people that we treat are coming within a 3 to 5 mile radius. We run our numbers off of how we will treat people within a 19-minute drive time of us being the circle dot in the middle. So that's 19 minutes just surrounding us. That's where people are coming from. We don't even look outside of that for patients. So the people we need to help are right here. And we hoped to work with the city of Everett and all of the people of Everett to help lower and stop the consequences of this preventable disease and addiction. So I'm open for any questions, and I provided a handout here, and just one thing I'd like to point out is we have a chief science officer. His name's Dr. Sherrick, and he actually is from here in Seattle area, and he is has run a lot of data on how we affect with crime, with the employment. Helping to get people employed helps to feel empowered to move on to different phases of their lives. It helped me a ton. So I guess I'll close with saying we're here to help, and anything that anyone would need, you can reach out to communitymedicalservices.com, info@communitymedicalservices.com, and or please reach out to myself at john.koch@cmsgiveshope.com. And thank you all for your time.
Awesome. Thank you, John. Thank you. for that. That was great. So this Everett Clinic isn't the first clinic in Washington or in the region. Can you share a little bit more about what other clinics are nearby and just how many numbers you're seeing and some of the success stories or success rates and just measurements of success in the other spaces as well?
Yeah, so here in Everett, you guys actually have what's called an OBOT, and that's another company. They're called Ideal Options. They run what's called an OBOT. It's office-based opioid treatment. It really is a doctor in doctor's office, and you just go in there and they prescribe one medication, not all three, but you know, they're doing the best they can to work with people. Outside of that, you know, here in Washington alone, you traditionally you're lacking treatment right now for a lot of your needs. If you've noticed, like, you'll see things with like Seattle saying things, different parts of the state saying different parts about lacking in treatment. Same goes for here in Everett. You know, the major population of those that we treat are from the age of 28 to 35, blue-collared individuals. And so that helps to bring you, that's a large part of the population here in Everett. So looking at that, you know, helping to reduce those numbers when it comes to it. So, and any other piece of your question?
Yeah, so are there other community medical services facilities in the area?
Yeah, so we're opening a clinic right now. So we're new to the state of Washington. That being, you know, we've identified just areas of need, right? And so here in Everett is going to be our first Washington clinic, but we're currently building out in Vancouver as well, and continue just to expand. It's usually you work through a couple sites due to, we're the most heavily regulated form of addiction or disease medication there is. So we're regulated by the DEA, SAMHSA, federal government, your state, your county. I mean, there's all different pieces to like the regulations that we have to apprehend to. So we figure those out kind of pilot. I wouldn't say pilot, we've opened a lot of centers, but we work through the different regulations as each states are different. And then from there, we're able to expand a lot more.
Great, and I think just to contextualize things as well, so earlier you had mentioned that the first clinic was in Phoenix and in Arizona, but then I forget how many clinics total you said are with the...
73 clinics, so we have clinics and they're not just in big cities across the United States. We have clinics all the way from Wasilla to Alaska to San Antonio, Texas. We have a lot of clinics in Ohio, Michigan, Wisconsin, and then Arizona. But yes, we're currently in 14 different states.
Great. Go ahead. Councilmember Schwab?
Thank you. You mentioned that a lot of your patients drive to your location
Yes, sir.
and they're blue collar. Could you walk me through maybe a patient that perhaps doesn't have a home?
Yep.
What does that look like?
Yeah, so I can walk you through my situation, what that looked like for me. So not having a home, officer where I was living at the time had come in contact with me a lot and says, hey, you know, kid, you need some help. Why don't you get some help? I was 24 years old at the time, and I said, okay, let's try something. And so brought me over to the clinic, right? At the time, I have nowhere I'm living. If I find somewhere that's warm for the night, this was in Chicago, I was lucky. So with that, I get brought into a clinic, and when you're brought into one of our clinics, you will go in, you'll first meet with a peer support specialist or a counselor, and they'll do a quick evaluation on you to see what the length of stay, or see what your length of opioid use has looked like, right? You know, some people are intravenous users, some people are smoking it, some people are snorting it. So kind of just seeing where you are at in your use currently, and then from there, helping to build a treatment plan around your needs. And the reason I bring up a treatment plan is because for a person that's experiencing houselessness, the treatment plan then addresses that houselessness. So what I would do is I'd say, what they did for me is said, hey, there's actually a residential treatment over here that you have a lot of stuff in your system right now, and we would like to get you a little more leveled out right now, so let's send you to that. If it's somebody that's just using opioids, and at the time, then they would see the doctor that day. They'd see the counselor, treatment plan, they get the medication started on it, but then our peer, our counselor, the whole time they're working to get them housing. So we know that it is very, very hard to stay off of drugs when you don't have a place to live. So our number one thing that we're checking on when you come into us is, where can we get you houses? I have people here right now that are employed looking to help coordinate housing, make sure that there's good enough housing for when we open, so that we don't have just people hanging out or anything like that. Because when it comes to it, we don't try to be like a punitive program, like harsh on people. You know, we're going to go to you, if say you're loitering, right, and that happens rarely, but when it does happen, we say, hey, okay, why are you loitering? Okay, you don't have a place to live. Let's help you with that. Second time it comes up and you're not like trying anything, working with us, we're still going to try. We believe in a 90-10 method when you first walk in. We're going to do 90% of the work to help get you to where you can do 90%. From there, after that, we will continue to work with you, but we have to transfer you to another facility at this time, because this process isn't working out for you after the third time, and we have to be good neighbors. So that's where we are.
Great, thank you for that. Yeah, and one more question. You said you work with a lot of community resources. I take it your organization has a lot of experience in that?
Yep.
And you have a strategy that you will come in and work with the local resources and nonprofits and?
Yeah, we actually, we do everything from hire consultants and to help make introduction to different leaders, we've been in the business for a long time, so we use our resources of people we know, like Dr. Sherrick that's here in Washington, knows some different doctors from different organizations, so meeting with them. But yeah, we have a very soundproof plan on how to network with other organizations and be a good partner.
Thank you.
So I was over at the jail this morning, and in chatting with them, it seems like the mass amount of cases that they get are fentanyl.
Yep.
And I had remember previous conversations with some folks from Ideal Options that the treatment avenues weren't as updated as they'd like to address some of the newer drugs coming in. And it sounds like that there's new issues on our streets with regards to drugs that are not responding to treatment. Can you tell us a little bit more about how you deal with those emerging issues?
Yeah, so as it's stated before, Ideal Options provides one medication in buprenorphine. So buprenorphine is not addressed to treat people with fentanyl use disorder. The reason being is buprenorphine has a cap on it. So you can only take so much of the medication, up to 32 milligrams. Some doctors will tell you even less, but 32 milligrams, and then anything you take above that, it will not react. Where fentanyl is such a powerful drug that it goes by the microgram instead of milligram, that the buprenorphine doesn't have much of effect on it at all. It actually sends the person into really bad withdrawals. But with methadone, you also, for buprenorphine, you have to wait 24 hours for the person to take it. That you do what's called a COWS assessment, and it's to see where they're at in the withdrawal process, right? And so with methadone, you're able to at least address that person immediately, as they don't have to be out of their system, or else they'll go through withdrawals like buprenorphine. But you're also, it's for what we have right now. So I'll tell you, for a person to go to detox, and all these are valuable resources too. A person to go to detox, it raises your likeliness of death by 3,000% in the current trend with fentanyl. A person to go to 28-day treatment without medication-assisted treatment raises their likeliness of by 3,000%. A person on MAT receiving counseling and treatment through that process, it lowers your risk of overdose by 60%. It's the only thing we're showing to work right now. So the drugs that they're talking about that are coming in is fentanyl, and then there's xylazine. So xylazine is not an opioid. It is a animal tranquilizer for cows. And they are lacing fentanyl, already one of the strongest opioids there is, with cow tranquilizers, putting people into long sedations. And so what we're trying to figure out is how to work with the xylazine. And so we have xylazine testing strips that are able to give to people to make sure, see if it's in their drugs or not. We're able to test we don't use drug test urinalysis as a punitive process. We use it as for individuals just to help with the treatment process. Like, hey, it helps people to be able to talk about things that maybe sometimes they didn't want to talk about. But xylazine wasn't coming up in those tests for a long time, so now it is. We're able to test for it. And yeah, we're just combating it day by day, trying to find the best answer. There's no perfect answer with this. So every person's kind of journey on it's different. We just know that our best, our best armor, our best tools we have right now is MAT mixed with counseling and any other forms of treatment. I hope that answers your question.
Great. So I guess I have more of a philosophical question for you, if that's all right. So from your lived experience and also from your work with community medical services, what about our system? And when I say our, I mean like, not like the city of Everett, but just like, in the grander scale of our system. Like, what about our system isn't working right now?
Whew.
With regards to opioid treatment.
What's not working? It's not actually the treatment that's not working. The treatment's working really well. It's the amount of stigma we have right now as a nation on people with opioid use disorder, right? Because since opioid use disorders really became a thing and affected, people that people care about, and from there, it's then turned into, it's no longer like about how it's turned into a lot of big business with some stuff, or not caring about the people as much. And so, but the stigma on the individual is what's really affected it. A lot of people blame that it's turned into a business, is what I mean. But it's the stigma. Like, I dreaded going to treatment because I thought and knew how people were going to talk and treat me when I did it. Even the people that worked in the facility thought they were of greater stature than I was as a person. And that's not how you treat people, right? And so what we've been able to do as a company is a person-first kind of model, person-centered model, to where, like I said, everybody's kind of journey's going to be different, where before, and with just addiction treatment in general, we said, let's stick you in a 28-day program. When you get out, let's hope that the past 30 years of your life are fixed off of that 28-day program. And then from there, you should be good. And we'll put you in a house with about 20 other people, and you live in that sober living until, you find a job and someday get out on your own. And that's how we dealt with everyone. And we can't do that. I know that what worked for me might not work for somebody else. So, instead of asking, our doctors ask, what has worked for you in the past and what hasn't. and they go able to use that information to get people to the best medication, also to the best resources possible.
Thank you. I came up with one more question, so now I have two more questions.
Okay.
The next one is, can you share a little bit more about the timeline for opening and all that fun stuff?
Yeah, so we enter in for permits and we go through the build-out process. Usually, depending on the city, I know that Everett told us it would probably be a 4-month process around that, which is a good amount of time to get your permits, but it's okay. We're, working with it, like we said, we work with the cities and the different groups. And so right now, they're currently doing the demolition. They did half of it, but wanted to wait until we got permits. So they're finishing the other half. We'll do the build out of the space but we have to get our permits for our build out portion. And then from there, what we do is, I've never been through a Washington state licensure, so some states are really great to license you. Oregon, amazing. Just license you, get you through the process, trying to get access to treatment to people. Some other states, not so great. So with that being said, we'll work with the state licensure board and all the different programs to try to get licensed as quick as possible, and DEA. And then from there, we'll hold an open house. So anybody from the city of Everett, please, over this next 6 to 9 months that it takes to get something like this up and going, please feel free to contact Community Medical Services, and then we would love to have you at our open house. And we do that because we're able to walk around and show people what it is we do. Show you what it looks like to dose medication, show you how safe it is in there, and how big the safes are, and nobody's going to run out with one on their shoulder, and show you what it looks like to receive treatment in a really nice therapy room. Some of our patients have not been in a nice space in a long time, so showing you that and how it's supposed to be treated is really a big part of our open houses.
Great, so it's looking like maybe like late spring for an opening then?
Yeah.
Good guesstimate. Go ahead.
Yeah, do you have a plan, like a neighborhood outreach plan? Or, I heard open house, but I was wondering if there,
Yeah, so we would do open house and then meeting with different, just like neighborhoods. So I've met with a lot of folks from the city, the county, and then, go by like the recovery cafes or try those different avenues of meeting different individuals that maybe know about this. I found that when you host like, so if I were to host like a church meeting, right, where we hold a learning session at a church, it usually doesn't go that well because the people that show up usually are not happy that people are going to be receiving addiction treatment near their neighborhood. So as much as I can, I try not to do as many of those because it doesn't give you one-on-one time with people. It's a lot of people standing in front of me usually, and they feel like I'm talking at them, and I'm not able to take in all that they have. So if anything, going around and actually meeting the neighbors, talking, knocking on doors, being a servant in that manner so that they can actually put a face and a phone number. Like, I'll share my business card with anybody, and I've shared my email address already, and, willing to talk to anybody about what we do. So that'll be the plan, is to do an outreach by probably foot with the local neighborhoods at this time.
I would really encourage you to use that process. I don't know if you have a radius that you are looking at in that particular location of going out and putting flyers out or talking one-on-one.
That's what we will. Yeah,
Okay.
we're
How
definitely.
far off, what kind of a distance?
So there's different, I'm guessing it'll be about your 500-foot marker or more.
Okay.
Each city has kind of a little bit different of what they look like or do with that. Some are most of them are 250, but usually you can do like 500, 700 feet circle around there, meeting with it, and then, you know, I'll meet with people that are beyond that range too. So you have to kind of draw a line somewhere.
So we have a system of neighborhood groups.
Uh-huh,
They're very vibrant. Some of them are very, very vibrant.
yep,
So if there is a neighborhood group meeting near that location, whether someone from your organization shows up, there'll probably be a good turnout of people wanting to have a conversation about it.
I would go to any we want to join those neighborhood
Okay.
groups. We don't
Yeah.
want to just be at one meeting. We want to join it and attend it on a monthly basis, be part of that organization.
And you know Roxanne from a organization called Faith Family Center, they're within about a
Okay.
mile or so from this location. That's exactly what they have done, is they've gone out and not just shown up at a neighborhood meeting, but actually continue to be a part of it and attend.
Yeah,
So not just the one-day crowd, but a continuation of neighbors that communicate. She's just made herself available, or someone from the organization.
and that process has gone pretty well for her
It
so
has, yeah,
far.
yeah.
Awesome. Yeah, that's what we would plan to do then. So usually we would come to a meeting actually and ask too, like, what do you think works best for your community? I mean, we're looking to talk to the most people and get the word out there, because we're not here to hide this. If we were here to hide it, we'd put it behind a building somewhere and lease some space that people can't see.
Thank you.
Great, any last questions? Great, thanks, John, looking forward to the open house and ribbon cutting and all that
Awesome, thank you all
celebratory
so much.
fabulousness, thank you.
Appreciate it, your time, and thank you for letting me answer your questions.
Thank you. Great, next on our agenda is a group discussion about next meeting proposed agenda items. We have a list of suggestions that we had come up with from previous agendas, or from previous meetings, including welcoming guests from Everett Community College's Early Learning Center to share more about the work that they're doing. Addiction treatment options in the city, which apparently we probably crossed that one off our list. Pathways and gaps for services. A discussion about homelessness prevention, including tenant protections and rental registry, which could probably be scheduled for maybe an October meeting or so. Welcoming guests from Snohomish County Human Services to share more about resources and resource and human services mapping. Next on our list was local crisis triage, I assume with relation to Compass Health and the work that they're doing. And then last on our list here, we had reports on successful projects that the city has funded, including the Everett Gospel Mission pallet shelters and Claire's Place and others. I wanted to add to the list a presentation or something along those lines from COET. I think council has been hoping to get a little bit more insight on the work that they're doing and what interactions look like, what types of services they refer to, and just kind of get a better glimpse into their day-to-day operations and the work that they do. So I'd like to add that to the list of discussion items. I'd also, since we are the Health and Human Services Committee, I thought either through this committee or maybe for the full council, to invite folks from Providence back to share more about the work that they're doing to support nurses and all of that exciting stuff. I'm not sure if that would be more appropriate for a full council discussion, or if we want to post them in our small but mighty committee. Other suggestions, thoughts?
I think we had tried to bring them back, and there was a reluctance to have them again a second time at council. So I think to this committee would probably be more feasible if we can't get them to the council.
I think your list is very good. It just need to prioritize and see what admin can help and support, and appreciate your support on all these committees too.
That's right.
We do have Everett Gospel Mission lined up for next month, so they're confirmed. and able to be here. And of course, like a lot of the community development team, so Julie, Lily, and then various members of her staff are out this week, so, and kind of overlapping. So I don't know for sure but once they're all back in the next, next week, et cetera, I can let them know about this stuff. And then, again, other concepts too, so.
I'm very intrigued, thank you for that. I'm very intrigued about Everett Community College's program. Not only are we providing a service, but we're also doing job training for our future childcare needs for the community, so I'm very interested in that. Of course, I'm not a standing member, but I'm very interested in watching it.
Great, yeah, I
Yeah.
think, especially with the ARPA resolution vote later today for funding for the ELC, I think that is a clear intersection.
It's on the list, for sure.
Great. So I guess it would be, in addition to Everett Gospel Mission and their update next month, I think it'd be great to have one or two agenda items just to fill out the full time, so.
Yeah, I had one other suggestion too. I know Councilmember Fossey is very involved in the recovery system and our prison system, which thank you for that. Not only maybe a short report on that field trip or someone from that service, but maybe someone from the Snohomish County Jail to do a presentation. Maybe we can do that in public safety or this committee. I'm interested in that. Yeah, thank you.
So with the Snohomish County Jail, it sounds like they do have a little bit of a different approach than they did historically, and so things have changed there with regards to their medical system and their treatment. And today they weren't able to provide actual data as far as who was percentage of the population that was dealing with substance use disorder or going through treatment, but having them come in and give kind of a presentation and an overview that specifically applies to the services there, people's tenure, like how long they are staying there, because they also have like a workforce thing that they do there as well, and the map. So I think that that's a great idea to have them come in and actually bring information. And I know that they're giving a presentation soon to the mayors, so they'll have stuff already prepped.
Yeah, they are actually scheduled to go to the full council on the 23rd of August. in a couple
Is it
weeks.
regarding all
It's-
of the above?
Jail services broadly,
Okay.
so, actually, maybe that could prompt, like, we want to dive in more on this, and, but I think Council President Stonecipher, like, this was a few months ago, I think Council President Stonecipher had met with, sort of done, I think, what you guys just did, and wanted to bring them for a briefing to council, and finally got it scheduled, so that's happening, but I think, it could be good to dive in
Well,
more here.
I certainly like the idea that Councilmember Fossey said about bringing some data. Thank you for that. It's very important. And if they could emphasize, I mean,
could-
jail costs are jail costs, We don't need to spend a lot of time on them necessarily justifying their costs, unless we're in negotiations or something, but certainly the treatment side, and walk us through when someone is incarcerated into their institution, what that looks like, if they have known addiction problems or obvious addiction problems.
For instance, when you go in, you take a UA, and so the percentage of the people that are going and getting booked, it would be nice to know how many of them are, percentage-wise looking at that data. And I don't think that they have data that actually shows how any of their workforce programs actually, or other programs, once they reenter or once they leave the facility, if they had any impact or any result. And I know that that is something that people are trying to get in data points these days, because that's helpful to know if the programs and what you're doing is really helpful. So it'd be nice to kind of know where those gaps are. But aside from that, our food resources that we have in the city. I know that there's been some issues and some shortages with some of our communities receiving food from food banks, and there's been serious budget cuts. And with the cliff that kind of happened with the federal money going away for a lot of the food assistance and pilot programs that were happening, I think that there's a little bit of a issue there. So I don't know if that's something to add in, because I know a lot of our local communities here are impacted by that food shortage.
Food resources, that's what I'm gonna put on for now. I'm gonna come up with a different title, but yeah.
Great. I had something in my brain and then it's not there anymore. But when it comes back, Jennifer, you're getting a call.
Yeah.
Great. Any other thoughts, questions, comments, concerns? Great. We will see you in September. Thank you. We are adjourned.